Welcome to Read-On Smart Review RadBio edition. We're tackling a really crucial radiation biology topic today, the effects of radiation on the developing embryo and fetus.
Yeah, and this isn't just, academic stuff. Understanding this is absolutely fundamental for patient counseling, for radiation protection, and yes, for mastering your board exams. We're going to break down the science, the timing, the doses, really pinpoint exactly what you need to know.
Absolutely. Think of this session as kind of cutting through the noise, giving you the essential framework and the specific details that matter most, whether you're looking at a study question or, making a real clinical call.
So let's just jump right into the core principles.
Yeah.
When radiation exposure happens during pregnancy, there are several potential outcomes we really worry about. These can range from lethal effects, basically, the exposure leading to the loss of the pregnancy, all the way through things like structural malformations, growth disturbances, and even functional impairments later on, like affecting cognitive development.
Okay, those are definitely serious possibilities, and I understand the timing and the amount of the dose are just absolutely critical in determining what happens.
Critically important, yeah. The sensitivity of the developing embryo and fetus changes dramatically throughout gestation. And look, the type and severity of the effect are profoundly dose-dependent. Now, most of these severe outcomes we just mentioned, things like lethality, major malformations, significant growth issues, or severe intellectual disability, these fall into a specific category. We call them deterministic effects.
Ah, deterministic effects.
Right.
Okay. What does that mean for how we, think about the dose involved?
It means there's generally a threshold dose. Below that dose, the effect is pretty unlikely to occur. But once you go above that threshold, the probability of the effect goes up, and importantly, the severity of the effect also tends to increase with dose. It's really a direct consequence of killing cells. If you kill enough cells that are vital for a specific developmental process at a really critical time, you see the outcome. This is fundamentally different from stochastic effects, like, say, inducing cancer.
Right, stochastic effects. Those are more about probability, not severity, and we typically assume they have no threshold dose, right? Meaning any dose, in theory, carries some probability, even if it's tiny.
Precisely. And that distinction, deterministic with a threshold versus stochastic without, that's absolutely central to understanding radiation protection limits for pregnant individuals.
Oh.
Oh, and before we dive too deep, it's probably a helpful context that, congenital abnormalities have a background rate anyway, about 6% in live births, maybe up to 12% if you include minor issues, completely separate from radiation exposure.
Okay, so we have this spectrum of potential effects, heavily influenced by dose, but you mentioned timing is also key. How does that sensitivity change, over the course of a pregnancy?
Yeah, this is where it gets really interesting, and it's maybe the most crucial concept here. The developmental stage at the time of exposure really dictates the primary risk. Let's break down the timeline.
Okay, first up, the very beginning, the pre-implantation period.
Right. This is roughly the first, say, 1 to 2 weeks after conception, before the embryo has even implanted in the uterine wall. It's just a small cluster of cells at this point. They're dividing really fast. But importantly, they're still largely undifferentiated. They haven't really committed to becoming specific tissues or organs yet.
So what's the main vulnerability during this super early stage then?
Well, the primary risk here is actually lethal effects.
Mm.
The embryo is surprisingly resistant to malformations during this period, but it's highly sensitive to being killed outright. It's often described as an all or none effect.
The all or none concept. Okay, what does that look like in practice?
Well, it means that if the radiation dose is high enough to cause significant damage, kill a critical number of those few crucial cells, the embryo probably won't survive. It might fail to implant or just be resorbed very early on. However, if it does survive that initial hit, the remaining cells are totipotent, meaning they can still become any cell type, and they can often compensate for the cells that were lost. So if the embryo makes it past this initial period after an exposure, the risk of major malformations from that specific early exposure is actually minimal.
So the big hurdle is survival, but if they clear that, they're generally okay from that particular early exposure, at least in terms of structural problems.
Exactly. Animal studies, like those classic mouse experiments where they gave 2 grays during pre-implantation, they showed really high rates of prenatal death.
Mm.
But the survivors, they often develop normally.
Got it. High risk of death, but survivors are generally spared malformations from that specific early hit. Okay, what happens next as things start getting more complex?
Right, so we move into the organogenesis phase.
Yeah.
This is roughly week 2 through week 8 post-conception, and this is just a period of incredibly rapid and complex development. All the major organs, all the structures of the body are being laid down.
I can imagine rapidly dividing and differentiating cells would be highly vulnerable. What's the primary concern now?
This is really the period of peak sensitivity for inducing major structural malformations. And since different organs are developing at slightly different times within this window, the specific type of malformation you might see depends heavily on exactly when the exposure occurs. Which organs are in their most critical developmental phase at that moment?
Like, what kinds of problems are we talking about?
Well, animal studies give us some pretty stark examples.
Yeah.
Severe head and brain defects like exencephaly or anencephaly, skeletal issues like stunted growth or deformed limbs, eye defects like microphthalmia, small eyes.
Wow, that's quite a range. And is the dose response here also deterministic, like you mentioned before?
Yes, absolutely. The incidence and the severity of malformations are dose-dependent. Again, animal studies are quite telling. Doses as low as 1 to 2. Grays during peak organogenesis in rodents can actually lead to 100% malformations in the surviving offspring. So there's a threshold, but it can be quite low during these really sensitive periods. And of course, severe malformations can also lead to neonatal death.
Okay, so preimplantation is about survival, organogenesis is about structural problems. What about the longest phase then, the fetal period?
Yeah, this runs from about week 8 post-conception all the way through to term. Major organ formation is largely complete by now. This period is primarily about growth and the functional maturation of systems that are already formed.
So the risk of those really gross structural malformations goes down significantly, but we start seeing other kinds of problems emerge.
Precisely. The main effects during the fetal period include growth retardation. This means the baby might just be smaller overall size, weight, and, importantly, have a reduced head circumference. We call that microcephaly. And this growth impairment can actually be permanent. The tragic data from the A-bomb survivors exposed in utero is just a stark example. They were, on average, shorter, lighter, and had smaller heads when measured at age 17.
A powerful, sobering, real-world demonstration of that. But I know the fetal period, especially certain windows within it, is also critically important for another major system, the central nervous system, right? The CNS.
Absolutely. Brain development is still actively happening throughout much of gestation. Neurogenesis, making new neurons, and that crucial process of neuronal migration where these new cells have to move to their final spots, those are vulnerable processes. And radiation damage during these times can lead to severe mental retardation. This is arguably the most significant and certainly the best documented CNS effect. The studies of the APOM survivors were really key in identifying specific high-risk windows for severe intellectual disability.
And those windows are just crucial to remember, aren't they, for boards and practice?
Absolutely. There's a peak sensitivity period, so you need to know this, from about 8 to 15 weeks post-conception. During this time, the estimated risk of severe mental retardation is approximately 40% per sievert of fetal dose.
40% per sievert. Wow, that's a remarkably high-risk coefficient for a single sievert dose.
It is. It really is. Then there's a period of continued, though lower sensitivity from about 16 to 25 weeks. The risk during this window drops to around 10% per sievert. So roughly 4 times lower than the peak, but still, significant.
And what about before 8 weeks or after 25 weeks?
The risk of severe mental retardation from radiation exposure during those times is considered minimal or pretty much negligible based on the data we have. So pinpointing the timing within the fetal period, especially figuring out if the exposure falls into that critical 8 to 15-week window, that is absolutely critical for risk assessment.
And microcephaly, the small head size you mentioned, that's often seen along with mental retardation, correct?
Yes, exactly. Microcephaly is a common indicator of significant CNS damage. Some studies have suggested a potential threshold, maybe around 0.06 gray or 60 milligray for small head circumference.
And the impact isn't necessarily just severe mental retardation either. I seem to recall reading about more subtle effects, like IQ deficits or maybe poor school performance, also showing a dose-dependent relationship during these sensitive times.
That's correct, yeah. It highlights that there can be a whole spectrum of functional impairments, not just the most severe outcomes. The thinking is the mechanism involves radiation, killing those rapidly proliferating and migrating neuronal precursor cells, or maybe just disrupting their ability to migrate properly to form the brain's complex structure. Animal studies and observations in A-bomb survivors, particularly those exposed to doses above about, say, 0.5 gray, showed things like ectopic foci, or heterotopias, basically, clusters of neurons ending up in the wrong places within the brain.
Fascinating and definitely concerning. Are there functional impacts on other organ systems during the fetal period besides the CNS?
Yes, while the CNS gets a lot of focus,
Mm.
and rightly so, damage to other developing systems like the kidneys, the hematopoietic system, the liver, even the gonads, can also lead to functional problems that might only show up later in life. So let's try and consolidate those dose thresholds we've been touching on for these deterministic effects. For severe mental retardation, especially in that 8 to 15 week peak sensitivity window, the risk really becomes significant above roughly zero point 0.1 to zero point 0.2 gray, that's 100 to 200 milligray. And for maybe the subtler effect of just small head size, the threshold might be down around zero point 0.06 gray.
These are relatively low doses compared to many, therapeutic radiation exposures. That really explains why radiation protection guidelines for pregnant individuals are so stringent.
Exactly. And it brings us right back to that absolutely vital distinction we made earlier between these deterministic developmental effects and the stochastic risk of cancer induction.
Yeah, this is such a core concept for the boards. Let's just lay it out clearly side by side for you listening.
Okay, on one side you've got deterministic effects, think lethality, malformations, growth retardation, severe mental retardation. These are about killing a threshold number of cells. They generally have a dose threshold, and the severity of the outcome increases with dose above that threshold. Preventing these is the primary driver for setting those strict fetal dose limits in radiation protection guidelines.
And then on the other side, you have stochastic effects. The big one here is the induction of childhood cancer. These are assumed to result from damage to a surviving cell, like a mutation or instability that leads to uncontrolled growth way down the line. The key assumptions here are NO dose threshold, meaning any dose carries some theoretical risk, however small, and the risk is about the probability of the cancer happening, not the severity of the cancer itself, which isn't dose dependent.
Right. And the pivotal study in this area is often considered the Oxford Survey of Childhood Cancers, led by Alice Stewart. It looked at kids exposed to diagnostic X-rays in uterotypical exposures in the low milligray range. And it suggested a small but statistically significant relative risk for childhood cancer, particularly leukemia, maybe around 1.4 to 1.5.
And that translates roughly to an estimated excess absolute risk of about 6% per gray of utero exposure. So for the typical low doses you might see in diagnostic imaging, the absolute risk is small, but, it's still an important factor in that overall risk-benefit calculation.
So applying these radiobiological principles in the clinic, well, it has some really profound implications.
Yeah, the first and maybe the most fundamental step is pregnancy screening. Just asking women of childbearing potential about pregnancy before procedures involving radiation, especially things like pelvic imaging or radiation therapy, it's standard practice and absolutely critical.
Absolutely essential. And if an exposure does happen, whether it was inadvertent or maybe a medically necessary procedure, then accurately estimating the fetal dose and providing really clear, compassionate counseling to the patient and their family is just paramount.
Right. And that counseling, it needs to cover both types of risks, doesn't it? The deterministic effects emphasizing the stage-dependent nature and the dose thresholds for things like malformations or mental retardation and the stochastic risk of childhood cancer. You really need to help the patient understand which risk is the main concern, given the estimated dose and the timing.
Exactly. And this is why we have specific fetal dose limits. Organizations like the NCRP set recommendations, for example, limiting the fetal dose to 0.5 millisieverts per month once a pregnancy is actually declared. These limits are specifically designed to prevent those most concerning deterministic effects, assuming a very low probability of stochastic effects at these levels.
And kind of tying it all together is that core principle of justification and optimization, right? Also known as ALARA, pronounced ALARA, as low as reasonably achievable. Any exposure has to be clinically justified, the benefit clearly outweighing the potential risks, and the dose must be kept as low as reasonably achievable while still getting the job done clinically. To help visualize how this vulnerability shifts across gestation, let's try an analogy. Think about building a really complex custom house.
Okay, yeah, I can picture that.
So the very beginning, you're just laying the foundation, maybe putting up the initial simple frame. This is like the pre-implantation phase. If something catastrophic happens right then, like, I don't know, a sinkhole opens up, the whole project might just be abandoned. It's kind of all or none. But if the foundation survives and the damage isn't total, the structure is still so basic and flexible that you can usually recover and still build a perfect house on top without inheriting major structural flaws from that initial problem.
Right, okay. So the early structure is resilient in terms of its eventual form, but maybe fragile in terms of just overall survival.
Exactly. Then you move into the next phase,
Hmm.
where you're building the really complex frame, putting in all the critical infrastructure, the plumbing, the electrical wiring, the HVAC system. That's like the organogenesis period.
Right.
This is incredibly busy, very specific work. If damage happens here, say, the wrong pipes get installed or major wiring is put in completely the wrong place, you're very likely to end up with significant structural defects in the final house, and the type of defect depends on which system was being actively installed when the problem hit.
Makes sense, yeah.
Yeah.
Damage at the foundation affects survival. Damage during the complex framework build affects the specific structure itself.
Precisely. And then finally, you get to the fetal period. The basic structure is there, the walls are up. Now you're doing the finishing work, installing the intricate internal systems like maybe complex electronics for a smart home, doing the delicate paintwork, the landscaping. Damage here isn't likely to make a whole wall fall down, right? No gross structural malformations usually, but it can absolutely mess up the functionality. Poor wiring means systems don't work right. That's like functional impairment. Maybe the final landscaping ends up smaller than planned growth retardation, or that sophisticated smart home system just never quite works correctly no matter what you try. That's like mental retardation.
Huh. That's actually a really helpful way to think about it. Different stages of construction, different vulnerabilities, and different kinds of problems if something goes wrong. I like that. All right, let's try and distill this down into some clinical pearls, the absolute must-remember points, especially as you're prepping for your boards.
Okay, pearl number one. The sensitivity and the type of effect are strongly stage dependent. Just remember, pre-implantation, that's 0 to 2 weeks, is primarily about embryonic death, often that all or none effect. Organogenesis, 2 to 8 weeks, is the peak risk period for major structural malformations. And the fetal period, 8 weeks onward, is where you really focus on growth retardation and critically CNS effects like microcephaly and severe mental retardation.
Pearl number two, you have got to know those CNS critical windows for mental retardation cold. Highest risk is that 8 to 15-week period. Remember, estimated 40% per sievert risk. Lower, but still significant risk is 16 to 25 weeks, around 10% per sievert. Minimal risk before 8 or after 25 weeks.
And pearl number three, get your deterministic versus stochastic straight in your head. Developmental effects, malformations, intellectual disability, growth issues, those are deterministic. They generally have thresholds, and the severity increases with dose. Childhood cancer induction, on the other hand, that's stochastic. Assumed no threshold, and the risk is about the probability increasing with dose.
To help remember those specific CNS windows for mental retardation, maybe let's try a quick mnemonic. We know the high risk is in the early to mid-teens weeks, right? How about thinking 8 to 15 weeks, extremely fragile, and then 16 to 25 weeks, still trouble but fading. EF, extremely fragile. STF, still trouble fading. I don't know, maybe a little cheesy, but it might help it stick for the timing.
Okay, sounds good. Time for a quick board blitz. Let's run through 4 questions based directly on what we've just reviewed. This will help you practice applying these concepts. Ready?
Bring it on. Let's see how well you're absorbing this.
Question 1. A pregnant woman is inadvertently exposed to a significant dose of radiation at 12 weeks of gestation. Which of the following developmental abnormalities is of greatest concern based on this timing? Is it A, failure of implantation, B, limb deformities, C, severe mental retardation, or D, neonatal death due to lung immaturity? So what's the key factor you're looking at there?
The timing. It's 12 weeks. That falls smack dab in the middle of the 8 to 15-week peak sensitivity window for CNS effects. So the greatest concern has to be C. Severe mental retardation, failure of implantation, that's pre-implantation, less than 2 weeks, limb deformities, more organogenesis, maybe 4 to 8 weeks. Neonatal death from lung immaturity isn't really a primary radiation effect at 12 weeks. So C.
Okay, question 2. The risk of severe mental retardation following in utero exposure to 1 sievert of radiation is estimated to be highest if the exposure occurs during which gestational period? A, 0 to 2 weeks, B, 4 to 7 weeks, C, 8 to 15 weeks, or D, 26 to 30 weeks.
Right, again, we're looking for that peak sensitivity window for severe mental retardation. Based on all the data, especially the A-bomb survivors, that's clearly C, 8 to 15 weeks. That's where you see that roughly 40% per sievert risk estimate.
Perfect. Question 3. The all or none effect, where radiation exposure leads either to embryonic death or to normal development without malformations, is most characteristic of exposure during which stage? A, fetal period, B, organogenesis, C, pre-implantation period, or D, neuronal migration phase.
Okay, the all or none effect.
Well,
That's the hallmark of that very, very earliest stage
right.
before implantation even happens. So that's the pre-implantation period, answer C. Like we said, damage there tends to either just end the pregnancy very early, or if it survives, the remaining cells can often compensate, generally avoiding malformations from that specific hit.
Got it. Last one, question 4. Which of the following is considered a stochastic effect of in utero radiation exposure? A, microcephaly, B, growth retardation, C, induction of childhood cancer, or D, congenital heart defects.
All right, stochastic effect. We define that as having theoretically no threshold, and the probability increases with dose. Of these options, the one that fits that description is C, induction of childhood cancer, microcephaly, growth retardation, congenital heart defects. Those are all considered deterministic effects associated with dose thresholds. Thinking about these specific windows and dose thresholds, again, especially those relatively low numbers for serious effects during fetal development, it really just underscores the profound vulnerability of the developing brain. It's quite remarkable.
Absolutely, and it highlights why accurate fetal dose estimation, which, let's be honest, can be really complex sometimes, and then sensitive, clear counseling are just absolutely essential whenever a pregnant patient has been exposed or, needs to be exposed to radiation. It's not just about quoting numbers back at them, it's about explaining what those numbers actually mean in the context of their specific situation, their timing, and always emphasizing that fundamental principle of keeping doses as low as reasonably achievable, LARO, whenever possible. This knowledge really forms the foundation for making difficult decisions and making sure our safety protocols are rigorously followed. All right, before we wrap up this session, because I know trying to keep all these weeks and percentages and effects straight for the boards can feel like trying to juggle, I don't know, radioactive
I
isotopes.
feel you there. It's a lot to retain.
It makes you wonder, how many radiation oncologists does it take to change a light bulb right after they finally pass their boards?
Okay. I'm guessing it's related to all this knowledge somehow. How many?
None. They just look it up on Radon SmartLearn.
Okay, walked right into that one. Fair enough. So, to quickly review our core takeaways from today's RadBio session then.
Right. The timing of radiation exposure during pregnancy is absolutely paramount. Remember, pre-implantation is mainly about survival, that all or none effect. Organogenesis is the big danger zone for structural malformations. And the fetal period is where you really worry about growth retardation and, most significantly, those functional CNS effects.
Yeah, and crucially, remember those CNS critical windows for severe mental retardation. Highest risk 8 to 15 weeks, lower but still significant risk from 16 to 25 weeks. And keep in mind, doses as low as 0.1 to 0.2 gray in that peak window are concerning thresholds.
We also clarified that fundamental difference between deterministic effects, the ones with thresholds, where severity increases with dose, like malformations and mental retardation, and stochastic effects, like childhood cancer, which are assumed to have no threshold, and the risk is about probability increasing with dose.
And finally, we touched upon those essential clinical implications. Things like rigorous pregnancy screening, careful dose estimation, sensitive counseling, adhering to strict fetal dose limits, and always practicing LRI. These radiobiological principles really are the bedrock for protecting our most vulnerable patients.
So here's maybe a final thought to consider as you go forward. Given how incredibly sensitive the brain appears to be to radiation during certain windows of fetal development, even at relatively low doses compared to other tissues, what does this unique vulnerability really tell us about the sheer complexity and delicacy of neurodevelopment itself? And how does that profound understanding shape our sense of responsibility every single time we plan or deliver radiation anywhere near a potentially pregnant patient? It really puts the biology into sharp clinical focus, doesn't it?
For complete practice oral boards and more in-depth RadBio reviews like this, make sure to visit radonsmartlearn.com. That's RADONCSMARTLEARN.com.
Thanks for tuning in.